And we have a second presentation now. And this one is going to be about the work that Isaac and others in the team here and in South Africa have been leading to design a intervention for people living with serious mental illness to act as peers and support the recovery journeys of those of other people with the same condition or a similar condition. So we have a very exciting opportunity to present this work at the Global Mental Health Summit in Cape Town. I know some members of our lab will be at the summit, but for those who won't be there, it really is the biggest mental health summit for our field happening, I think, in years. And it's really a great opportunity to share some of the work we're doing around this field, this topic. What's interesting about the summit is that it's co-hosted with the Global Mental Health Peer Network, and I think some of our colleagues who are joining from South Africa are active members of the peer network. And so, in a way, this is an opportunity for us to give feedback to Isaac and others about the structure of the presentation, and that. So it's really about hoping to sort of shape the presentation into one that is going to have the most impact. And I'm assuming you're going to make a presentation and then have questions as well on what, where you're struggling in terms of content. Okay, yeah. Terrific. Isaac, over to you.
Can we tap Sandra and Alex to see if we can?
Oh yes, could we just introduce who all are going to be there?
Yes, so you all know Laura and I, so there's no need for our introductions, but Alex and Sandra, if you all are able to hear us, it'd be great if you both could introduce yourselves really quick.
Yeah, hi everybody. Hi Harvard team. I'm Alex Sheehan. I will be a discussant panelist with the wonderful team here here in just a few short weeks. I live in Washington State. I have been an active member of the Aves Mental Health Global Mental Health Peer Network for a little over a year now, and by day I work in state level mental and behavioral health care policy, program development and implementation and things of that nature for Washington State. And as said here, I'm also doing a Doctor of Public Health at Tulane with research focusing on the impacts of lived experience, consultation, and embeddedness on innovative and sustainable state-level mental health care policy. So that's a little bit about me. So I'll give it to Sandra.
Thanks, Alex. Hi, everyone. Happy to be here. My name is Sandra Ferreira, and I'm based in Johannesburg, South Africa. I am currently the Global Network Manager for Aves Mental Health. So very happy to be here and part of the team for this very exciting project. Thank you.
Thank you both. So jumping straight into it, our first section, we're going to talk a bit about the peer support landscape and really coming to common grounds about what even is peer support. So peer support, how we perceive it in the US, is not necessarily how we can define it on a global level. So peer support really encompasses this broad range of approaches in which people with living or lived experience of a mental health challenge support one another. It can be both formalized or informal, and we really see this in international contexts where in the US, for example, it's often delivered by a trained peer supporter or a staff member, but in international context, it's often voluntary roles or in a more ad hoc capacity. So while we're used to it being more formalized in the US, it's also much more voluntary and not as straightforward in international contexts. At its core, though, regardless of the context that we're talking about, live and living experience is at the core of peer support. This means that not just diagnosis specific, as in I have XYZ, but really if you identify as having a mental challenge, navigating that system, and that you can offer some form of support or mentorship to others similarly experiencing those challenges. It includes tasks like recovery planning, so setting up goals and working with your peer to identify what even is recovery and how do I get there. It includes sharing local resources and helping them access them. It's often strengths-based rather than treatment or medicine specific. And ultimately, it centers around mutuality, human rights, and empowerment, and really having the person with lived experience lead their recovery. This history of human rights centeredness is not new. I remember one of our conversations with Vikram that I always think about is how peer support is considered this hot and sexy thing in research, but it actually has an extremely long history going all the way back to the 1780s and the French Revolution. So in the 1780s, we had it first come up as this idea of moral treatment and really being pioneered by Hussein, and this idea that the asylum is not working, and really survivors of the asylum revolting and really demanding a humane form of mental health treatment. From that came the birth and really the popularization of mutual aid societies, and this belief that the current system is not working, and people with living experience deciding we're going to create our own system of aid and our own system of supporting one another rather than rely on a system that criminalizes us. We see this history and really this roots of nothing about us without us and creating support systems for one another throughout the entire history of the peer movement. In the 30s and 50s, we particularly saw within especially Western society, peer support become more formalized, first within the context of Addiction and Alcoholics Anonymous. The 12-step model grew popular in the US around this time period, and Australia also developed their own model. Throughout the 60s and 70s, we saw the rise of the consumer and psychiatric survivor movement, which also coincided with decolonial movements occurring in South Africa or Africa, Asia, and other grounds that really was creating the framework for what does community solidarity look like, especially within a lived experience framework. We also see from this is also widespread deinstitutionalization and really the closing of multiple asylums across Western society, both here in the US and Europe. Going to the 80s, 90s, and 2000s, we start to see peer support increasingly become recognized and formalized. First, with the creation of peer-run centers and mutual support groups becoming popularized, and peer support starting to become an actual service provider across the US and Europe. And in the last 20 years or so, we've seen peer support become an actual formalized intervention and field, with in the US, SAMHSA recognizing it as an evidence-based and Medicaid reimbursable service, and other international contexts also recognizing it as a provider type. And this is just an example, another depiction of what the global peer landscape looks like. This is an image from Aves Mental Health, the Global Mental Peer Network, which is really showing how peers are everywhere. Peers are represented by Aves Mental Health from across 51 countries, and it shows how the lived experience community is not in this silo of just where peer support is formalized, but really how the lived experience community is strong and spans across regions of the globe. Aside from its rich history, there is also increasing evidence in the literature that peer support is an effective model of mental health support, comparable to other interventions. So this is just a handful of studies that we are using as an example, but this is just, again, a handful of the overall rich breadth of literature that's there. Peer support has been evident to increase self-efficacy both in the US and Germany. One of the biggest studies, which is the Upsides trial, compared peer support and its effectiveness across 6 different national contexts, including Germany, the UK, Israel, India, Uganda, and Tanzania, and it found improvements in social inclusion, empowerment, hope. You also see clinical and social recovery outcomes are increased, empathy and acceptance, and social support and social functioning among people with mental health challenges. Peer support is not only a helpful model in terms of overall emotional well-being and recovery support, but also when it comes to clinical symptoms, as well as hospital admission rates and readmission rates, as we see in the studies depicted there. Now, we've talked a bit about why does peer support work, what is peer support, but the question is always why is the peer workforce not large enough, or why are there not enough peers in the current ecosystem? And that's primarily due to a lot of the gaps that we see listed here. First of all, there is a clear lack of role clarity and really role implementation. A lot of the, in contexts where peer support is formalized, there is not ever clear job descriptions. There is a lack of a clear understanding within the teams about what is a peer supporter, and ultimately promotes things like peer drift, which is when the peer role becomes something it's not, which promotes things like burnout and ultimately people leaving the peer workforce. So even after they've been trained, we are not having people sustained within the system. There is inconsistency with training, both in contexts like the US where it is formalized, and also where there are contexts where there is no training that exists. Here in the US and other contexts abroad where it's formalized, peer support trainings can either be inconsistent in the quality, the topics they cover, whether or not it's in person or virtual, whether or not there's a cost associated with it, the extent to which they have practice and other hands-on experiences offered in their training. And so even for people such as myself, when I was initially trained, that posed a really huge barrier of, okay, on paper you're trained, but you still lack the skills to actually deliver this intervention. There's also ultimately the power of stigma and power dynamics, where even in systems where mental health may be perceived as less stigmatizing, staff and medical staff particularly may themselves reinforce medical hierarchy, ultimately again, reducing sustainability for peers in these roles. And lastly, there are systemic barriers, really how things like funding streams, the availability of peer support services. In the current geopolitical climate, a lot of peer support services and trainings are starting to collapse due to the lack of funding across the globe for mental health and lived experience initiatives. And so this is increasingly becoming a barrier to sustaining and expanding the peer workforce. So that is where our initiative comes in to hopefully fill in these gaps, which is the Empower Peer Support Initiative. Many of the gaps, like you mentioned, like inconsistency in training, accessibility barriers such as in-person modalities and synchronous trainings, are all being addressed through our initiative, which would be an asynchronous, globally adaptable digital curriculum, training people with lived experience to gain hands-on, to gain those skills to become peer supporters themselves. Much like I described earlier, our curriculum centers lived experience leadership, leveraging existing and newly formed partnerships with people with lived experience and experts in the field to develop this curriculum. Our peer supporters, when trained, will be able to provide emotional and practical support to others, not just seeing the mental health side, but also very practical things like resource sharing and other tasks. The final curriculum that we've developed is an asynchronous skills-based one composed of 11 modules, and it covers topics such as, again, lived experience and how do you strategically share to inspire hope, crisis response and intervention and prevention, advocacy, justice, and more. I will now pass it to Laura to talk a bit more about how we actually designed the curriculum.
Thank you, Isaac. So I'm going to give an overview of all the data collection that we did to arrive at our final peer support curriculum, and we'll give you a little look about what this is as well. So for all of our interventions that we develop in our lab, we use an approach that triangulates different data sources, which helps us understand what evidence already exists that we may want to look at and incorporate into our training. We also do our own primary data collection, including surveys, key informant interviews, focus group discussions, in order to collect data, because oftentimes what we see existing in the data is not everything that we need in order to create a full curriculum. And then most importantly, we include an expert advisory group that will guide us along the entire process of developing curriculum, interpreting the findings that we see in the data, and making sure that we're really aligned with what the experts and their lived experience say in the field. For our Empower Peer Support curriculum, other things to highlight that are important too is we worked alongside SATI, an organization within India who is also creating peer support curriculum specific to the Indian context. This was highly valuable for us because we were able to meet with them very regularly throughout both of our processes and understand what are we seeing as relevant within a US and then expanding to a global context, and how is that aligning with what they're finding in the Indian context as well. And this is valuable because we can see overlap between our curriculum and theirs and understand what is globally relevant in all different contexts. And I'll also highlight a landscape analysis, which we intended to do ourselves, but we were pleased to see that the Peer Recovery Center for Excellence already had a very recent landscape analysis that assessed the availability and implementation practices of peer support. And this was specific to the United States. But this is a framework that we started with and then conducted a systematic review. So I'm going to walk through the findings from our systematic review and our survey and qualitative data collection. The Empower methodology that we use, and Empower is kind of an approach in a suite of digital training curriculums, and mostly this thus far, till we've gotten to peer support, has allowed for task shared interventions to train non-clinical providers in a clinical intervention. So some examples of interventions through Empower are some of transdiagnostic intervention for youth and behavioral activation, which is for adults with depression. But this is taking a clinical intervention into a community workforce. We're understanding what we're doing with peer support is very different. It's not clinical intervention. It's explicitly alongside clinical interventions, but with the focus on using one's own lived experience. So our methodology for all of our Empower interventions, after we've done our research and built out a curriculum blueprint that we feel confident about, is we move into the digitization process, where after we have our blueprint, we move into scripting. We use our scripts to create videos and corresponding competency assessments. So we know that when people go through a digital training, they sometimes have the head knowledge, but it takes practicing and role plays and actually speaking the skills out loud in order to feel fully confident to move into intervention delivery. So we want to make sure that we have the tools to assess their fidelity to our model and also rate competency, so people are fully prepared as they move into service delivery roles. And before we create our maybe we should change this to this video production is sort of before here. Anyway, we also ensure that we are co-creating our digital content with our target audiences and involving people with lived experience throughout the entire process. And one thing that has been very important to us from the beginning of peer support curriculum is to design a curriculum that wasn't just coming from Harvard. So we're at Harvard Medical School. Some of us on our team would identify with people with lived experience and others would not. We didn't want to be co-opting and moving into a space where there has been trust broken in the past. And it was really important for us to have an approach that focused on power sharing and not just us coming in with our own ideas. And we also know the quality of our work really improves when it's informed by people with lived experience who have experience with mental health conditions and also experience working as peer supporters in the US and globally. Some of the strategies that we incorporated to make sure that we were considering power sharing throughout our whole process is having conversations with people that were within different states in the US and globally as we considered where we might pilot our curriculum. And if there was already something in existence that people felt very positively towards, we would not want to replace it with our own curriculum. So we're really looking for the gap. We want our curriculum to address a gap, not to come in and squeeze itself in and fit where there's something that's already working really well. We also intentionally hired Isaac, who is somebody who is able to toe the line between the research world that we live in and the peer support world. So Isaac has experience as a peer supporter and lived experience with a mental health challenge as well. And having him on our team is really invaluable. And I can speak for myself that oftentimes he knows the landscape so well in the US and now globally too, that he's able to point out, who's the right person to actually hire to script our curriculum. And what are the right conversations? What are the questions that we need to be asking to make sure that we're designing curriculum that fits well and is sharing power and is ethical the whole time. Finally, throughout multiple processes in our data collection, we were doing our survey, taking it back to our expert advisory group with our findings, conducting our key informed interviews, taking our guide back to our expert advisory group, compiling all of our findings and interpreting it along with our expert advisory group. This was a very important process to make sure that we were not thinking with our researcher head so much, but also understanding the nuances and making sure that what we were interpreting was accurate and then could go into the informing our peer support curriculum that we eventually created. So I'll show findings that triangulate really all three of our primary data collection sources in addition to our systematic review. So we started out with a systematic review where we created a competency taxonomy and we actually coded different skills and competencies that peer supporters reported using in the interventions that they were delivering. So our systematic review included 41 different trials, and the top 3 competencies that we saw were collaboration and care, providing support, and communication. So these are the skills that peers are using in peer support interventions. This was secondary data. A lot of these trials were a lot older. So in our survey, we had 101 participants responded. All of our participants in the survey had experience working as a peer supporter. And we saw a lot of overlap here. You can see collaboration and care and communication were 2 of the top 3, in addition to sharing lived experience of recovery. So this was still found in the systematic review, but I think what was really unique about sharing lived experience of recovery is peer supporters that were currently engaging in peer support, whereas some of our systematic review had trials in the early 2000s. So it really shows that this has become a skill that is more necessary and more commonly practiced in more recent peer support. We expanded on what we saw in our secondary data collection and our survey data by conducting key informant interviews and focus group discussions. So we could see a list in the previous slide of how often a peer supporter indicated using that skill, but really wanted to understand from a more qualitative perspective what peer supporters were doing within their roles, how they defined their roles, both their current roles, but also their ideal roles. What should the role of a peer supporter look like? And this is important for us as we're designing what we hope to be more of an ideal curriculum. So this indicated to us that peers really respected mutuality, shared decision-making, and personalization to support their peers. I would say it confirmed our quantitative findings, but also expanded beyond that and gave us examples of what this looked in practice. The first quote points to how the role of a peer is defined. And oftentimes we can say somebody's a peer because they share a demographic characteristic, but really what sets peer support apart? So they say people can be peers to each other for lots of different reasons. They can be classmates, they could be women, they can be all sorts of things that positionally put you in peer relationship with someone because of an affinity group that you belong to. When positionality is around the mental health condition, the mental health struggles, or navigating those systems, because similarly, you've done that yourself, I'll call that peer with a capital P. And any other kind of peer support is peer with a lowercase p. This was helpful for us in talking to this person in a key informant interview, because what our curriculum focuses on is peer with the capital P, as they define it. So we are specifically wanting to focus on people who have that lived experience of a mental health condition and helping them harness it and use it as a powerful tool for delivering peer support for those that also suffer from mental health conditions. And our second quote also supports the idea of collaboration and shared decision-making, mutuality. There might be a peer supporter who isn't a fan of medication, but the person they're serving wants to take medication. It's our job to support them and figure out how they want to do that. We're not enablers of people. We are supporting people to be as independent as possible. So there were a lot of quotes that aligned with this belief as well, which pointed to the fact that even power sharing must happen in the peer support relationship too, where it's not coming in, and a lot of people have had negative experiences with clinicians in the past in some circumstances where it has been more of a treatment that's forced upon them. They're not respected as somebody with agency. We wanted to make sure that our peer support training really encompassed this, and we're enabling people to be power sharers in their peer support roles. Our data collection also asked about training experiences. So we asked about the training duration, format, and the content as we were thinking about what our final curriculum may look like as well. In our systematic review, we saw that it was most common that trainings took place in person and in the course of several days. So it was a synchronous training. This was confirmed partially in the survey as well. About half of them were in person, half were online, but the costs for in-person trainings were reported to be a big burden that prohibited people from getting the training that they wanted. There was a little bit more, I will say our survey respondents were 50% in the US. So I think this shifted the mean number of hours of training a little bit higher. And we saw a variety of that around global settings as well. And in focus groups and key informant interviews, we asked more about this. So we saw these two different options, this in-person synchronous option, the hybrid option where it's a little bit online, a little bit in person. And in qualitative data, participants said that they really saw the flexibility and accessibility of online and asynchronous options, but there was a lot of shared value in being in the same room, being online at the same time, and building the community through the training as well. So there are pros and cons to both approaches. In terms of training content, a lot of the trials in our systematic review were very structured around a specific peer support intervention that was already developed, something like RAP or bridges, and several referenced role play content as part of the training. In our qualitative data collection, when folks spoke about the training content that they did see or that they wanted to see representation, which was very important, especially when taking this to a global context. Didn't want to be reinforcing this dichotomy of somebody that was white in the service provision position who's always in a position of serving someone who's non-white. So we wanted to break that stereotype through our curriculum as well. And there were some concerns that we noted on, will things be able to translate to cross-cultural settings? Will the language be able to translate? Is it as simple as just dubbing it? Or how important is it to actually see people that look like they're from your culture and hear your own language in the training as well? So things that we keep in mind as we're thinking about a curriculum that can be readily adapted to many settings. And in supervision, in the systematic review, we found that supervision consisted of reviewing fidelity ratings and the intervention content, discussion of any problems that had arisen during the intervention delivery. We did see that supervision took place in both group settings and in-person settings. And interestingly, supervisors were typically a researcher on the team, a clinician, and very infrequently they were a more experienced peer supporter. But we saw in our qualitative data collection when we asked about this that peers indicated a really strong preference in all settings for being supervised by a fellow peer supporter. They saw the value of working with clinicians. They didn't want it to be a supervisory role. They want it to be a collaboration role. They wanted somebody who had experience and expertise as a peer supporter that they could go and ask questions to. Nearly half of our survey respondents had previous experience as a supervisor. And once again, our survey respondents were peer support workers. And of that, only 62% of the respondents had received training in supervision. So that goes to show that most people are working as supervisors without being ever told how to be a supervisor. So that's something we wanted to consider as we developed our curriculum as well. One quote from an interview said, "I had no senior peer on my team or anyone to learn from. If you're not a self-starter trying to seek community, it's like you're kind of lost at sea. You don't really have anyone to ping your ideas off of or talk through scenarios with, especially if you don't have a peer specialist as a supervisor. We have a clinical supervisor, it makes it even harder." We did look at barriers and asked about this in both our survey and our qualitative data collection, and this highly aligned with the barriers that Isaac presented in the last section of what's already been noted in the literature on peer support service delivery. I will say the one thing that might be a little new, well, peer drift kind of aligns with lack of role clarity, but often, especially in our focus group discussions and key informant interviews, folks give a lot of examples of being asked to do roles that they did not think were the roles of the peer. So moving beyond that taxonomy that we had developed and asked people about in the survey, where we had coded peer support competencies, they were saying, we're actually not doing that. We're doing more clinical roles or more clerical and administrative roles, which is not how they saw themselves using their expertise and their lived experience in their roles. And that could be largely pointed to a lack of supervision, sometimes poor collaboration across the mental health ecosystem, and often just barriers with a lack of workforce in general. They're working at a clinic and get tasked with doing all sorts of things rather than being there to do what they envision their role to be most useful for. For format and accessibility, many trainings were reported to be inaccessible due to costs. Like I mentioned, the cost of traveling in person and staying somewhere to attend a training, lack of financial support opportunities, the compensation, and the quality and availability of training was also very inconsistent, often listed to be poor in either non-existent in global settings or sometimes often poor in US settings. And then finally, participants noted inequitable compensation, feeling like they either weren't paid enough, and not knowing, well, what do I do next? Which also is aligned with lack of supervision training. So there wasn't really a way to step up and become a supervisor as a peer, or it was unclear what they would do after being a peer support worker for a while. And in the meantime, they're paid an hourly rate that they felt was sometimes unfair and made it difficult for them to do their job in the long term without burnout. Those are our findings. And then we thought, okay, taking this back to our expert group, what does this mean as we develop our peer support curriculum? So we noted many barriers to training. So we've created a training that is asynchronous, digital, and easily adaptable to contexts. And when we have done this, we've highlighted specific parts in our scripts where we think are US specific, but tried to make sure that what is in our curriculum blueprint is relevant to our findings that we saw cross-culturally as well. So we're trying not to give examples that are very US centric, or trying to show a diversity of people within our training so they don't all look traditionally as American. And what's important about our training is that while it will come in an asynchronous digital format, there's also many ways to make this an in-person training too, if that's what's desired at the organizational level. So we noted very different needs in different contexts, and part of what makes it adaptable is the fact that it could become an in-person training. We do this for our other Empower interventions too. In our work in Japan with Empower Youth intervention, we're taking something that's a digital training that's asynchronous and turning it into an in-person training. So it's always a possibility. We want to make sure that our curriculum is set up in that way too. We noted frequent reports of peer drift and lack of role clarity, and peers saying, well, I don't know what to do when I'm being asked to do something clinical, but I don't want to do that. I'm not good at that. I'm good at this. So we have specific lessons in our curriculum on collaborating with the mental health ecosystem, such as clinicians and supervisors, and trying to empower people to be supervised well. So advocating for their needs with their supervisor. And in the future, it could look like actually having modules for supervisors too, and supervisor training. We saw that existing trainings, especially in the US, were missing key skills like career growth, which was reported as a big need and something that was very valuable to peer support workers, advocacy justice, and also working across the mental health ecosystem of people that were not peer support workers. So we've included modules on each of these topics in our curriculum. And finally, we received a lot of feedback from our expert advisory group about new training content and revisions to language and blueprinting. We wanted to make sure that we're saying something in the right way, and that we're not using any jargon or words that sound too clinical or too research. So one example of this is due to, and they're also helpful by saying, this is something that's required in our state. So if you ever wanted to work in our state, here's a quick lesson you could throw in and check the box that would allow people to be certified in the future. So an example of this is including a digital literacy model and making sure that it was really tailored to the peer support work that we're doing. So we had 11 modules that we created, and here they are all in order. We also got feedback on the order of our curriculum. We wanted to make sure everything flowed really well and that people were learning something after they've had the relevant background content. So our first module is just a general introduction to mental health and well-being, peer support basics. What is peer support? Kind of thinking of what does it mean to be capital P, peer support. Communication, which is a skill relevant to really any service provision, but we really thought that that was important to have the soft skills in here too. Sharing lived experience to inspire hope, personalizing support to the person right in front of you, our digital literacy model, and then collaboration across the mental health ecosystem, preventing and responding to crises, justice and identity, ethics and guidelines, and then professional development and career growth. And then when we are in South Africa, we will have a video to show and a little module, which we do not have that yet, but. All right, I'll turn it over to Sandra.
Right, excellent. Thank you, Laura. And Isaac, I just want to check if my connection is okay. It's a bit.
Yeah, we can hear you.
scattered.
We can hear you
Excellent.
all good, Sandra.
Great. All right. Thank you. Before I get into the bulk of my section, I just wanted to do a brief introduction to our organization for those who aren't familiar with Aves Mental Health. So Aves Mental Health was formerly known as the Global Mental Health Peer Network and was established in 2018 by Charlene Zunkel. We are an international organization that builds capacity among people with lived experience of a mental health condition. Isaac did show a representation of our global map in his section as well, but just to reaffirm, we are divided into what we call the 4 quarters of the world. We have representation across 51 countries and growing, and we are represented by 171 what we call experts by experience for the purpose of this presentation, peers and people with lived experience, and we speak from one unified voice. You can also see here representation per income country. It's important to note that the majority of our representation is across low and middle income countries. Obviously, the importance here is because low resource settings have less access to mental health services. And important, obviously, to this conversation or today's presentation is peer support and the lack of formalized peer support or peer support training for people with lived experience. And that speaks to quality and access as well. So speaking as myself and as part of the membership as well, there is a very clear need for an evidence and experience-based peer support curriculum. It's important for me to highlight the word experience. As Laura has spoken about quite a bit as well, this curriculum was co-developed by many of our members, which is very important to us as an organization as well. Next slide, please. Right, I'm going to localize this a little bit as a South African and as a service user who's been using services for over 20 years. So recent data from a South African perspective suggests, it's not just a suggestion, it's a fact, that mental illness has now exceeded HIV in terms of the burden of illness in South Africa. This is obviously cause for concern and marks a critical shift in public health priorities and an urgent need for scalable community-led responses. I highlight the word community-led because that emphasizes the importance of leading with people with lived experience. Despite this need, there is no recognized form of peer support available in South Africa, and it's really not something that is part of the mental health space at the moment. It's very informal in conversations, but more than that, you don't hear much of it within the South African space. So here's the opportunity for innovation, and with this empowered peer support curriculum, what could it do within a South African space? It would equip people with lived experience to deliver evidence-informed, recovery-orientated support. It would strengthen mental health service capacity, especially in low-resource settings. So this extends to not only urban areas. We have a lot of rural communities in our country, and this has the ability to reach those communities, to reduce the pressure on existing mental health systems, and then finally to contribute to job creation and skills development within the mental health sector. The unemployment rate in South Africa is one of the highest globally. I think we're sitting at about 33% at the moment. So peer support is not only a bridge to care, but an economic catalyst. This is something that is quite idealistic in my view, but it has the potential to change the future for the youth and people with lived experience in the youth bracket. Next slide, please. Right, so lived experience leadership. Again, Laura has spoken a bit about this, but I just wanted to highlight it again, and the relevance and the impact of co-designing with representatives from aves mental health. So people with lived experience were actively engaged in this curriculum, and what does this do? Evidence supports that when you involve people with lived experience in your initiatives or your projects, this positively impacts on outcomes. This ensures that the curriculum reflects real world needs and experiences. Also, with our diverse representation, so we have obviously members from across the globe, this increases cultural relevance across diverse backgrounds, and very important, leads to more practical and empathetic approaches to support. We really center the word empathy within our space. And this, as I say, this curriculum, as it is co-developed with people with lived experience, that's something that you will be felt through this work. It strengthens community ownership and autonomy for those who have been involved, and the long-term sustainability of the curriculum as well. Empowerment and inclusion are very important to us as people with lived experience. It's not just about recovery and being well and remission and all these clinical terms. It's about our own personal empowerment, self-efficacy, self-worth, etc. And all these things fall within this bracket. So it recognizes the value of lived experience expertise, and this curriculum also promotes shared decision-making and equitable collaboration, and I can attest to that. It further supports empowerment and recovery for those involved in the co-design. So it seems like a side note, but it is not fundamental, but it contributes greatly towards people's recovery when we are involved in projects and initiatives such as this. Next slide, please. Right, then finally, so obviously our organization, one of our pillars is peer support. We advocate a lot around it, and we recently released the position statement ahead of the upcoming G20 summit, where many government or world leaders will be meeting, calling to action to integrate, peer support into mental health reforms. The Empower Peer Support curriculum is not only a tool to bridge care gaps, but again, a powerful aid in peer support advocacy. Here I've shared a couple of quotes from our members, sharing their experiences and what peer support has meant to them. We have a number of members who contributed to the statement and also contributed their personal quotes. And I'm just going to self-reflect on this one just a little bit. So I have said on many open forums how important peer support has been to me in my wellness and my recovery, and I regard it as one of the vital pillars of my wellness. As I've mentioned, there's no form of formal peer support in my country available to me, but even the informal nature of peer support through our network and being around like-minded individuals, people who have had similar experiences to me, has really been a massively contributing factor to where I am today. And that's me. Thank you.
Great. Thank you, Sandra. We will now go to Alex to present a bit about some additional commentary and the ways in which our curriculum can be applied to the broader lived experience community globally.
Yeah, thank you, everybody. So really awesome to get to come at this from a kind of a outside looking in perspective in this light, and kind of in looking at it and in, kind of weaving in my own lived expertise by experience. When we look at like the global mental health landscape today, I think a very stark reality stands out that, there's vast treatment gaps and workforce shortages that really continue to undermine care. In many countries, there's fewer than one psychiatrist or, traditional mental health professional for every couple 100,000 people. And that is just, it's mind-boggling. And it's proof that traditional mental health, like specialist and provider-driven models simply cannot, not even sustain, they can't even scale to meet this need. And that's where, peer support comes in. And it's not just this, cool, shiny bauble or a nice idea. It's a necessary strategy and a focal point because people with lived experience really bring that trust, that credibility, that empathy, and that relational connection that is often missing. We understand, stigma not from theory, but from reality. And when peer support is truly engaged, you can see this bridge start to form that, between access barriers and normalizing, seeking help and support. And that's why I found, in my opinion, that Empower's model is really, really compelling. It's evidence-based, it's digitally enabled and designed to really build capacity in community systems by training non-specialists to deliver, these psychosocial interventions. And by doing so, we're strengthening mental health equity, which I think is a really important part here, at least in my own experiences and my own work, which really acts as a catalyst for reaching really deeper into communities that are often excluded from care. And finally, to this point, this element that I see is this backbone of Empowers is the sustainability. So task sharing and community engagement. This program I see doesn't replace specialists. It just simply shifts part of that load into community hands where it has always belonged, meaning care is closer. It can be more culturally embedded and linguistically appropriate and ultimately more resilient because in today's mental health ecosystems, peer support it's not a gap filler. It's the movement towards a paradigm shift towards community healing and really shared ownership of what recovery and, going from surviving to thriving can really look like. So in my view, as somebody, with, experience through, serious mental illness, this initiative really matters because it doesn't expand services. It fundamentally shifts who delivers care and, more importantly, how it's delivered. And that shift right there in and of itself really has the power to rewrite mental health systems for good. Next slide. So moving into kind of like this, question of sustainability, I think, scalable training is not simply about adding more people. It's about building consistency, credibility, and quality across every peer support setting. And within Empower, this model trains peers at scale so that we don't just have, peer support everywhere, but we have it that's effective, it's replicable, it's trusted. Second, the design matters. And I think that the kind of modular architecture, so to speak, of this program really allows every setting, whether that be rural, urban, suburban, high resource, low resource, to be able to replicably scale and adapt the training locally without losing the evidence-based standards, the efficacy, or the fidelity that you've worked so hard to create and co-create. And that flexibility in and of itself ensures relevance while the structure preserves quality. And third, and this one was touched on by Lara, Isaac, this is just, I think, a resounding piece here, co-creation. That's a big thing for me. I'm not somebody who ever says doing things with or doing things for. It's co-creation, co-production. Those are my things. And I really like that Empower bridges like rigorous intervention science with lived experience, not for lived experience. And I think that's the coolest part ever. It shows that evidence-based methods and lived expertise by experience can and do coexist powerfully when done correctly. And this is, this right there is peer work done with and not to systems. Considerations about sustainability, I feel like often stop at inclusion or are, kind of parallel to things that already exist that we're not even changing. But inclusion, in my opinion, is just, it's not enough. Acting in parallel to care does not rewrite systems. What sets this model apart, I think, is this focus on interwovenness, integration, and embeddedness, really putting these peer roles in formal systems, not siloing them, and that sustainability develops or depends on institutional support, funding, supervision, and without that, peer programs can oftentimes remain side projects. And finally, this point that community matters. Future sustainability in this regard, demands co-production, ongoing supervision, shared community stewardship and ownership, and peer supporters, communities, and lived experience voices must shape and govern and own these interventions together and not just simply deliver them. So in sum here, for peer support to last and be matter, I think it has to be, I like to use this a mentor taught me this um thing about the ampersand and. So it has to be scaled and integrated. It has to be adaptable and evidence-based, and has to be community-led and system embedded. It has to be all of these things, not one of these things. And I feel like Empower really presents that opportunity and, lets us know that the real work is really truly embedding these into health systems so that peer support isn't optional, but instead it's seen as foundational. And last slide. So as we step back, I think, and just kind of as I, look back at the big picture, I see this question, this resounding question of, how do we move from isolated programs to like really true systems level transformation where peer support is really interwoven into the fabric of our care. And I use the word our very strongly. And I feel like Empower's model gives us just a glimpse of what systems change really looks like when we center the lived and lived experience voice. First we need to see peer voices recognized in the frameworks that govern health. So everything from policies, reimbursement systems, program development and implementation and evaluation and care models, because when lived experience is built into these structures, peer support and peer work shifts from the margins to the actual core and the heart of that work. And transformation really requires more than participation. And again, it goes back to this notion of co-creation. Communities and peer support groups must share leadership, share decision-making, and really help define what success means, especially particularly when we look at metrics, that reflect compassion, equity, trust, and cultural relevance. And another piece here being that connectivity. Peer support organizations don't operate solo. Take aves mental health, for example. This has to be one of the most fantastic examples of what it looks like when you don't just have a network of people that come together all over the world, but when we work with other networks doing similar tangential parallel work, our work and our presence just becomes that much stronger. And then there's this piece of sustainability in the workforce. For peer roles to endure, funding must be stable, career pathways must exist, and ownership must be like emphasized and local. And this means that models driven from the community and by the community rather than for the community. And to my last point, this, I feel like transformation and, this accountability really asks us to make a commitment to collaboration at every level and transparency through leadership, through policy, service delivery, and peer support. And this means mechanisms for accountability to those served, support for peer well-being and growth, and even openness about, outcomes, missteps, lessons learned. So in short here, and I'll end it with this, I think systems change is really not about layering peer support on top of already pre-existing systems, because I think time and time again we prove that a lot of the time these just don't work. It's not enough. But it's about reimagining systems with peer support really interwoven into the fabric as central actors. And I feel like the Empower model, with its structure, with its training, with its very clearly evidently community-rooted design, gives the world this really cool blueprint, making it easier for systems to, adapt, embed, and if needed, evolve accordingly. So that's me. Thank you.
Great. Thank you so much, Alex, for your comments. So we want to end off our presentation also with gratitude and thanks. This is just a glimpse of truly the village that has created this curriculum. Of course, there's our lab team, the Sangaf team, the aves team, our expert advisors, the consultants who led our assessment and scripting, and the funders for our curriculum and Dear Foundation and the Princess Foundation for South the India curriculum. This is our contact info, which we present there. And for you all here in the lab, we have a few facilitating questions that we hope to have as guidance for the conversation we have after this conversation. But as always, thank you so much for letting us take some of your time, and I look forward to your feedback. Please be nice. I'll try.